That's a wonderful question. The first question is wonderful actually. So the doctor was asking, can we prescribe empagliflozin as a first drug of choice without metformin? Is that the question, right?
Yes, sir.
Okay, I can give you the answer with evidence-based medicine. See, the first international body that has said that you can use the SGLT2 inhibitors or the GLP-1 receptors, GLP-1 receptor agonists, the injectable anti-hyperglycemic drugs, are put together in a newly detected patient in the absence of metformin if the patient is at risk of developing atherosclerotic cardiovascular disease or heart failure, or already has developed atherosclerotic cardiovascular disease or heart failure. See, the first body is the European Society of Cardiology, has said even before Corona in the 2019 the scientific sessions of European Society of Cardiology, where I was there actually, physically I was present. It said very clearly, even without going for metformin, you can start either empagliflozin or dapagliflozin in case the patient is newly detected, is or at risk of developing atherosclerotic cardiovascular disease or heart failure, or the patient has already developed atherosclerotic cardiovascular disease and heart failure. And it also said that if it is an atherosclerotic cardiovascular disease where atherosclerosis dominates, you have to go for a GLP-1 receptor agonist. Where heart failure predominates, your drug of choice must be an SGLT2 inhibitor, preferably empagliflozin. That's what it said. And in case the combination you want to use, the GLP-1 receptor plus SGLT2 inhibitor, that gives a great benefit to the patient even in the absence of metformin. Later on, the EASD, that is European Association for the Study of Diabetes, has joined hands with the European Society of Cardiology by giving a joint consensus, like European ESC bar EASD joint consensus treatment for the type 2 diabetes in the presence of atherosclerotic cardiovascular disease and the heart failure, said the same, can be started without initiating metformin. You can straight away initiate this particular molecule alone or in combination with the GLP-1 receptor agonist. I think the doctor is satisfied, I think. The doctor can raise the, you can unmute yourself and ask the question, no problem. You are most welcome, okay?
And then we have second question.
Yeah, tell me. Please, somebody, can you just mute yourself, please? Yeah.
So what is the frequency of euglycemic decay with use of gliflozin?
See, it's more of theoretical importance. So far, I have not seen in my clinical practice the euglycemic decay so far. As long as the patient is adequately hydrated, as long as the patient follows all the precautions what I said, as long as the patient doesn't require insulin. See, it happens only where in the patients they have type 2 diabetes, wherein they require the insulin, they'll end up in that particular problem. So far, I have never seen. This is of the more of a theoretical importance rather than the clinical relevance. But the other complications I said, the dehydration and the recurrent genital urinary tract infections and the recurrent the candidiasis, I've seen quite large cases. Yes. Next question, please.
Sir, can you use gliflozin in pre-diabetes as a monotherapy instead of metformin?
No, absolutely there is no indication. Say as of now there is no recommendation from any international bodies like American Diabetes Association or the International Diabetes Federation or the European Association from the clinical the study of diabetes ASD or the American College of Endocrinology or the American Association for the Clinical Endocrinologists. These are all the major international associations which have never said that you can use the gliflozins in pre-diabetes. The only drug of choice is metformin, that too after lifestyle modification and therapeutic lifestyle changes. Without that, you are not going to achieve anything. You cannot reverse pre-diabetes just with metformin. See, in addition to diet, exercise, reduction in the weight, cessation of smoking if applicable, cessation of alcohol if applicable, add metformin 500 mg, then increase it to 1000. Even the patient requires, you can go up to 2000 milligrams in Indian scenario, whereas the cutoff for the Western people where the body mass index is more, the cutoff is 850 TID, that is 2550 milligram. For us, always make it a point, you should never exceed the dose of 2 grams, that is 2000 milligrams of metformin in two divided doses. 1000 in the morning, 1000 in the evening is the maximum dose you can go. And you quickly escalate, like okay, start with 500, after 15 days or 1 month you go to 500 BD, after 15 days you go to 1500 and again go to the 2000 milligrams in pre-diabetes. So you can make it very fast. But what is more important is, again and again I tell you, metformin is not the important, and there is no role for SGLT2 inhibitor. Empagliflozin is not indicated for patients who are suffering from pre-diabetes, but lifestyle modification and therapeutic lifestyle changes are more important than the metformin. But metformin off late has got its own pleiotropic benefits, which make the patient from the reversible state from pre-diabetes to normal, that is the normal patient, normal individual actually. It's okay. Next question, please.
Yes, sir. Sir, how to decide dose of empagliflozin between 10 and 25?
See, they say there is nothing like 10 and 25. You think that the patient cannot tolerate a lean type 2 diabetes patient comes to you, you can start with 10 milligram and escalate to 25. Finally, you need to escalate to 25. 10 milligram is only a starting dose. It's something like a step 1 strategy, and the lifetime maintenance with 25, because all the trials are done with only 25 milligram. That is the only one thing you can, or else you can straight away go for 25 milligram. But all the companies, I don't know the strategy behind that. Okay, they come with 5 milligram DAPA and 10 milligram PA. Though all the trials are done with 10 milligram of DAPA, all the trials with 25 milligram of DAPA. Likewise, canagliflozin also, all the trials are done with 300 milligram. But we have 100 and 300. Likewise, stepwise you want to escalate, you can go for 10 milligram of EMPA, and the next month the patient is quite good and all, everything is fine, no complications and no adverse effects, you can escalate to 25. Is it clear? Next question, please.
Sir, should we stop gliflozin in T2DM once we switch to T2DM to insulin therapy?
Absolutely not. Absolutely not. See, it's a very good question actually. So I need to give some explanation. See, the greatest, the positive effect of this particular the molecule, the DPP4 inhibitors and the SGLT2 inhibitors is that they are compatible with all the drugs. They are compatible with metformin, thiazolidinediones, and the alpha glucosidase inhibitors, and the GLP-1 receptor agonists, and insulin, and all the the anti-diabetic drugs are the only thing you have to remember is whenever the patient is going, the clinician is going for insulin when the patient is on this particular SGLT2 inhibitor. So if the patient is on sulfonylurea already, you need to reduce the dose of sulfonylurea drastically to prevent hypoglycemia, and also to initiate insulin with low dose, because in the presence of the sulfonylurea or the insulin, when the patient is already on the SGLT2 inhibitor, that may result in hypoglycemia. That's not because of SGLT2 inhibitor, that's because
Sir,
of
last 2 minutes, sir.
yeah, per se the sulfonylurea or the insulin. So you need to reduce the dose of sulfonylurea or begin with low dose of insulin, so that slowly escalate if the patient doesn't get into hypoglycemia. Yes, tell me.
So
Yeah,
last
next
one,
question.
but not least, any difference in therapy modularity in pre-diabetes of IFG and IGT?
Pardon? Any difference
in
between?
any difference in therapy modality in pre-diabetes of IFG and
Acha,
IGT?
so okay. The treatment differences in the IFG and IGT. So when compared to IGT, IFG is a milder form actually. So because IGT is related with the increased cardiovascular complications and the kidney effects. Either the 3-point MACE or the heart failure is more seen in IGT rather than the IFG. But there is no difference absolutely. But you need to be more cautious. You need to hit early, hit hard in IGT cases, so that you need to make a proper diagnosis of IGT. Means you have to go for a nosy TT with 75 grams of glucose in patients with the equivocal patients. That is the random blood sugar shows somewhere around some 160 170, then that is the case, the patient should go for 75 gram OZTT. Then only if the OZTT shows around or more than 200, then you can label it that's from 140 to 199, you can label it as IGT. So IGT has to be taken care aggressively when compared to IFG, but treatment remains same. Only thing is needs a lot of counseling. You need to stress about the complications. You need to stress about the reversal. The pre-diabetes, the IFG can be reversed or the IGT can be reversed with diet, exercise, and the reduction of weight, the smoking and all the alcohol I said, and with metformin. There is no difference. There is no other drug to be used in pre-diabetes except as far as this pre-diabetes is concerned, the only recommended drug is metformin. No difference, absolutely. Any question, please?
Sir, no question, sir. With your permission, can I close the session?
Yeah, if there is no question, you can wind up this session, Ramesh. And thank you so much from my side. The wonderful participation of my professional colleagues and wonderful interaction. And thank you, Boringer people, for giving me an opportunity to be the speaker of the evening. Thank you so much. I sign off. This is Dr. Sepuri, endocrinologist. See you again with a beautiful topic again.